All right, the purpose of this presentation is to present some current concepts in concussion assessment. The components of concussion assessment should generally be based around these three big bullet points. You have to talk to your patient about their symptoms and get them to tell you what they're experiencing. But again, as I mentioned in the last presentation, we have to do this multimodal type of assessment, so we can't just rely on symptom self-report. We also need to test how the patient's brain is working, and there's a variety of ways to do that. In the SCAT form, SCAT 5, there are Maddox questions that are meant to establish retrograde amnesia, and then there are immediate and delayed recall tasks that we can do to assess cognition, so those are assessing the patient's anterograde amnesia. We also need to assess the physical aspects of our brain function, which one way to do that is postural stability. So we can do a balance assessment and we can test balance and sort of proprioception, whether the patient is static or dynamic. So in order to assess these things, the symptom self-report, the cognition, and the postural stability, we can use a series of assessments. And you don't have to do all of them, but we can use standardized concussion assessments to evaluate some of these things. So the best test is the balance error scoring system. SCAT 5 is standardized concussion assessment tool, and then we can do the Fukuda test, which always makes me think of Dr. Cutter because it's one of his favorites. And then we have this new one, and I have it in all caps because it is new and it's very interesting. Shows a lot of potential to be very helpful in concussion management. And that is vestibular oculomotor screening, or VOMS. So these are considered standardized assessments because they have been tested, they have been developed in a way to be objective, and so we can say, for example, on the BEST test, there's been enough normative data collected, they've tested enough people to be able to say the average person should be able to have less than 12 errors on a balance error scoring system. So the concept of standardization is a couple things. That the assessment has been shown to be a valid measure of whatever you're trying to measure. In the best case of the BEST test, it is balance. But also the concept of standardization is that it has a system of administration that is consistent every single time. So for the BEST test, there are specific directions to read to your patient. For the SCAT 5, similar situation. You're going to say the same thing to every patient. And that's another thing that makes it standardized. So it's standardized because of the way that it's administered. And then it's also standardized because there is data to help us interpret those results. So what should a patient score, for example? All right. So we'll look at a couple of these. I did want to point out, though, that there are non-standard concussion tests. The Rongberg test, which is a single leg, stance type of a test. Tandem walk, where you walk heel to toe, perhaps on a straight line. Cognitive tasks, a non-standardized cognitive test would be to ask your patient to subtract 7 from 100 continuously until you get to 39 or something. You could have the patient do coordination tests, see if they're able to stretch their arms out fully, like fully extended elbows and wrists, and then do a finger-to-nose test just to see if they're able to do it. But with the non-standardized tests, you kind of never know what it is you're supposed to expect your patient to do. So you can do the results and you do the test and sort of look at the results and subjectively say that looks bad or that looks good, but you don't have a lot of data to support it. Another example of a non-standardized test is the CRT5. I'm going to pause on my concussion test to talk about this one. So the CRT5, pretty sure I have it up here. Here's the SCAT. Okay, and here's the CRT5 right here. Okay, so the CRT5, check this thing out, is meant to be, there, now we can make it bigger. Okay, it's a tool to help identify concussion in children, adolescents, and adults. Essentially, this thing is only telling people what the signs and symptoms are and what they should do if they detect the signs and symptoms. So this is put out by the Concussion in Sport group that did the consensus statement, the Berlin statement that I reference a lot. And this is meant to be the thing that coaches and parents use to detect sport concussion in their children and in their athletes. And so then they would refer them. So this isn't something that an athletic trainer would use, and this is not something we're deriving a score from, but it is something to look at, or some information to give rather, to these folks who aren't trained healthcare professionals to be able to detect concussion. Okay, so I'll close that one. We'll come back to the SCAT-5 in a few minutes. All right. Again, non-standardized. We don't give it the same way every time. There's no someone saying this is the best way to do it and this the best way to score it and then the best way to interpret it. That doesn't exist for these things, but it does for these things. So these are better. Okay. Again, we want to go over a little bit about the SCAT-5. So that's one of our major standardized assessments that we are using. Many of you, or if you haven't read this already, that's one of your assignments in our modules to go ahead and read this whole thing. Some of you may have done it because you've used it already in your clinical practice. Okay, so the SCAT-5 has in it a symptom self-report, and what you have here are 22 symptoms, and the person, so you would read to them, in fact, I'll go back to the SCAT and read this. What they're telling us to do in SCAT-5. So here's the page. Whoops, that's not it. Here's the page of symptom self-report. I'm going to zoom in on it. I'm going to turn off my sidebar. Okay. So in terms of this being a standardized assessment, there we go. The athlete should be given this form and asked to read the instruction paragraph out loud and then complete the symptom scale. Okay. For the baseline assessment, the athlete should rate his or her symptoms based on how he or she typically feels. And for the post-injury assessment, the athlete should rate their symptoms at this point in time. So if you're doing it, there's an important aspect of concussion assessment is to do a baseline assessment. So you hand this to the patient, and they're going to say, if I don't have a headache, they're going to circle 0. If they do have a headache, they're going to rate it from a 1 to a 6. Okay, so with your symptom report then, again, they're reading all of these things, responding. If they don't have it, it's a 0. If they do have it, they're rating it from a 1 to a 6. And that's going to give us, or the way that you're going to score it, they're going to hand it back to you when they're finished. So you're going to add up the total number of symptoms, and that gives you sort of an idea of the variety of their symptoms. And then you get a symptom severity score by adding up all the 0s, the 1s, the 2s, the 3s, all the scores. Add them all up and get a score out of 132. Ask their patient if the symptoms get worse with physical activity or mental activity. Okay. If 100% is feeling perfectly normal, what percent of normal do you feel now? And you would record that as well. So again, symptom self-report is an important aspect of concussion assessment. This is a pretty detailed form right here. The problem that I have had in using this is that it is the easiest thing to ask your patients. It's an easy form of an assessment to do, but it's also easy for them to lie. So then we have to incorporate those cognitive tests and those postural stability tests in order to make sure they're not lying to us. All right. So just as I mentioned before, we have physical, cognitive, emotional, and sleep questions on our symptom evaluation. Okay. Also, the SCAT-5 is assessing cognition. So in your initial assessment, before you get into the full-on concussion assessment, and what I mean by that is at the time of the injury, you would want to ask the patient, you tell them, I'm going to ask you a few questions. Please listen carefully and give your best effort. First, tell me what happened. And so you would record here what the patient told you had happened. And then you want to ask them the venue we are at today, which half it is now, who scored last in this match, what team did you play last week, and did your team win the last game? So this is a series of yes or no questions to test for retrograde amnesia. They're very broad, and they're just getting us a yes or a no. So right now, the purpose of these Maddox questions, what we're seeing is this is to get an idea of whether cognition is impaired. Okay, so again, this kind of points us in the right direction when we're doing our initial assessment. On a follow-up assessment, we're looking at these things on the right-hand side over here: orientation, immediate memory, concentration, and with the concentration, we're doing digits backwards and also months in reverse. So we are going much more in depth with our questions, and now we're starting to give a score. So again, the Maddox questions, that happens at the initial assessment to figure out if you are concerned about a concussion. And if you are, you go on and do the orientation, what's the month, what's the date, what day of the week, what year, and what time. Immediate memory is a word recall. The digits backwards is a digit recall, and then the months in reverse. So this is a pretty robust way to test brain function. Okay. Okay, so in looking at postural stability, you can measure or assess rather static postural stability. So what the patient's able to do without moving using the BEST test. So, or you could do the Fukuda test, which is more of a dynamic test. So BEST test involves standing still under 6 different conditions with your eyes closed. And the conditions are double leg stance, single leg stance, tandem stance on a flat surface, and then repeating those stances on the foam pad. And we're going to do this one in class. But keep in mind that as we're doing this postural stability, what we're doing is we're saying the brain really has 3 sources of input to help it maintain the appropriate position, to help maintain postural stability. So proprioceptive, through sensors in your joints and other tissue, are feeding information to your brain. You have your eyes, then you have your vestibular system in your inner ear. So on these tests, both the BEST test and the Fukuda, we take away the visual and we tax more the vestibular and the proprioceptive to see how our patient responds. The Fukuda test is one where the patient marches in place either 50 or 100 steps, and what you're interested in is let me back up. They stand with their eyes closed, shoulders flexed to 90, and then they begin to march. And again, it's 100 or 50 steps. And as they are marching with their eyes closed, the clinician is monitoring them to see if they walk forward, if they veer off to one side, or if they rotate. And any of those, if they go too far forward, veering off to one side, or rotating, could be considered a positive test. And you would think that the patient possibly had vestibular impairment because of that. And so that's a test that I've seen Dr. Cutter do on a number of occasions to assess the patient's postural stability as part of a concussion assessment. All right, so now we have our vestibulo-ocular screening. And I have an extra slide in here. I'm not exactly sure why. Also called VOMS. And your VOMS testing relies on your, the VOMS testing is an assessment of your vestibular system. So our vestibular system has both a sensory and a motor function. It is involved in our perception of motion and our orientation of where we are in space. And then it also controls our eye movements, our maintenance of equilibrium, and our desired posture. So it's both sending off sensory signals and then also controlling motor function. That's why it's called, that's one of the reasons it's called an ocular motor screening. So with our vestibular system, we can evaluate our vestibulo-ocular reflex. And this is kind of an interesting thing. When a patient maintains eye contact on something that's straight ahead and turns their head from side to side, the eyes reflexively move in the opposite direction that the head moves. So you have the ability to maintain gaze stability is a way to think about it. I can maintain focus on a particular object even though my head is moving because of my vestibulo-ocular reflex. And that's an important thing that can be impaired in your patient and a good way to identify deficits that happen with concussion. Okay. All right, so what I want you to do is I want you to watch these demonstrations, right, these videos of VOMS testing, of vestibulo-ocular motor screening for the sports concussion. Here's the names of the test right here, and here are the videos. So if I click on this, it'll take me to a series of videos.
We are now going to demonstrate the VOMS, or the vestibular-ocular motor screen, which...
All right, so I want you to watch those videos, and we'll go over these tests in class. We need to talk a lot more about our VOMS testing. Okay. All right, so our head injury assessment then should use a funnel approach. In our differential diagnosis, you have to keep the skull injury and the cervical spine injury in addition to the brain injury. And then we're going to do an on-field assessment to begin ruling those out. We're going to do an off-the-field assessment to begin ruling those out, or we know, and then come up with a clinical diagnosis. Okay, so always thinking about skull injury and cervical spine injury, rule them out before you assume that it's, quote, just a concussion. Okay, for the concussion assessment, we must use a variety of tests: symptoms, cognitive assessment, physical aspects of balance, and the vestibular function. And it's also very important to stay informed of new concussion assessments because concussion research is ongoing and fairly intense right now. So we find out new things about concussion all the time.